Hi, welcome to the CEU course, How CMS Goals, Payment Models, and Quality Incentive Plans Align to Promote Home and Transplant. Today's topics include the history of Medicare coverage of the end-stage renal disease population and an overview of the following: goals, payment models, and quality incentive plans, the 2020 Advancing American Kidney Health Executive Order, the CMS ESRD network goals, the ESRD QUIP, the ESRD treatment choices model, the kidney care choices models, and the measurement assessment tool that is used by the Survey and Certifications group. You will also learn how the presented goals, payment models, and quality improvement plans align to promote home and transplant at the dialysis facility. By the conclusion of this course, the learner will be able to understand the history of Medicare coverage of ESRD and the history of the ESRD network organization, be able to articulate the goals of the 2020 Advancing American Kidney Health Executive Order, comprehend the CMS ESRD network goals for home therapies and transplant, verbalize the ESRD QUIP measures as they relate to transplant, identify the purpose of the ESRD treatment choices payment model, and understand how to identify if their facility is participating, understand the kidney care choices models, and identify the state surveyor measurement assessment tool requirements for home and transplant. Lastly, you will be able to align the CMS goals, payment models, and quality incentive plans with your day-to-day work to promote home and transplant modalities. Section 1 is going to provide a history of Medicare coverage and the ESRD network organization. So what is the history of the end-stage renal disease coverage from Medicare? This is important to learn as the remainder of the course builds upon what was once established. So in the 1940s, modern dialysis was developed. Then in the 1950s, the first successful kidney transplant occurred. Despite these early advancements, there was a systemic issue with the availability of treatment. For those diagnosed with end-stage renal disease, if treatment was available, there was also the constraint of hefty medical costs, which left many Americans unable to obtain treatment. In 1965, Congress established the Medicare program for U.S. citizens and any permanent residents over the age of 65. The Social Security amendments of 1972 extended Medicare coverage to individuals who needed dialysis or transplantation to maintain life. This extension allowed for medical coverage for individuals suffering from end-stage renal disease regardless of age. After the Medicare program was extended to cover those with end-stage renal disease, cost saving became a focus for the government as they now absorbed all of those medical costs from ESRD. Medicare initially paid healthcare providers separate amounts of money for their care to include tests, supplies, drugs, and overall services provided. To help control costs, Congress implemented the Prospective Payment System, often abbreviated as PPS, in 2011 for Medicare dialysis services. Under the payment system, payments are established in advance, based on an episode of care, regardless of the actual care conducted. We're now going to switch focus and go over the history of the ESRD network organization program. So what is the history? Once Medicare was extended to cover end-stage renal disease, there was an identified need to promote more effective coordination of the Medicare ESRD program. In June of 1976, regulations were published which included the implementation of the ESRD network organization. There were 32 ESRD networks established to manage different geographical areas within the United States and its territories. Since the implementation, the number of networks has decreased from 32 to 18. These 18 locations are highlighted on the map. We're now going to switch to Section 2, which is the current state of Medicare coverage for end-stage renal disease for 2022. The first topic we're going to cover is the 2020 Advancing American Kidney Health Executive Order. Keep in mind, we're just going to briefly cover this. So the AAKH, as it's often abbreviated as, was developed and unveiled by the White House and the Department of Health and Human Services. The order's objectives are to reduce the risk of kidney failure, improve access to and quality of person-centered treatment options, and increase access to kidney transplants. There are many proposed payment models included with this executive order to test the effectiveness of increasing home dialysis and transplantation and supporting nephrology care upstream before a person reaches kidney failure. These payment models will be covered throughout this course. Here's an infographic of the Advancing American Kidney Health Executive Order. The top section identifies goals. The bottom section identifies two payment models. The Department of Health and Human Services, who aided in the development of this executive order, have three main goals based on the order. The first goal is to reduce the number of Americans who develop kidney failure by 25% by the year 2030. The second goal is to ensure that 80% of new kidney failure patients in 2025 are either receiving dialysis at home or receiving a kidney transplant. The underlying goal for this is to provide patients who have kidney failure more options and better options for treatment. This can be done by utilizing today's technologies and future technologies such as artificial kidneys. The third goal is to double the number of kidneys available for transplant by 2030. To hit any of the proposed goals, there needs to be more organs available for transplant. The next topic we're going to cover is the CMS ESRD Network Quality Improvement Goals. Once again, we're just going to cover a brief overview of this section. As mentioned in the history section, the ESRD Network organization was created in 1976 after there was an identified systemic need to promote effective coordination of Medicare's end-stage renal disease program. The ESRD networks act as the administrative governing body and a liaison to the federal government. Network 1, which is the New England area, Network 2, which is New York, Network 6 of the South Atlantic, which is comprised of North, South Carolina, and Georgia, and Network 9, which is the Ohio River Valley, are all managed by IPRO. All four networks make up the IPRO ESRD network. CMS relies on the network organizations such as IPRO to develop a relationship with dialysis professionals, providers, and patients, and create a collaborative environment to improve patient care. One of the primary functions of the network organizations is to assist CMS in understanding the needs of the ESRD patients by including patients in quality improvement activities and meetings with CMS. CMS directs the network organizations through the development of a contract. CMS reevaluates the quality improvement activities in the contract and the goals that we are required to meet annually. The current contract for the network organizations has quality improvement activities to increase the rate of kidney transplants and increase the rate of patients on dialysis at home. These quality improvement activities were developed to work in line with the Department of Health and Human Services work and other goals in the ESRD sector. The current statement of work contract provided by CMS runs from 2001 to 2026. There are two goal areas: improve the education and access to empower patient choice of home modality, and improve the choice of transplant. So first we're going to cover home modality under the ESRD network quality improvement goals. The choice of home modality enhances the patient's quality of life and is more convenient than traveling to an in-center clinic 3 times a week. Patients have also experienced better blood pressure control, fewer hospitalization, also known as better quality of life. Dialysis patients need education and support to determine the appropriate dialysis modality that fits their lifestyle, including but not limited to how each modality affects travel, diet, and fluid consumption, school, work, social interaction, and overall well-being. The goals set by CMS are, by 2026, per the Statement of Work contract, achieve a 60% increase per network service area in the number of incident patients starting dialysis using a home modality. Incident patient means new end-stage renal disease patient. Each year, there is a new goal to reach, which will equal a 60% increase by 2026. The second goal is by 2026, per the Statement of Work contract, achieve a 30% increase per network service area in the number of prevalent patients moving to a home modality. Prevalent patient means existing ESRD patient. Each year, there is a new goal to reach, which will equal a 30% increase by 2026. The second CMS ESRD network quality improvement goal is improve education and access to empower patient choice of transplant. It's very similar to the home modality one, but this one is focused on transplant. The benefits of transplant extend to end-stage renal disease patients regardless of age, gender, or ethnicity, as well as those with common comorbid conditions, including diabetes and hypertension. A kidney transplant is the preferred treatment modality for end-stage renal disease. A kidney transplant can provide a patient with a better quality of life. Patients who receive a kidney transplant also have a longer life than those that continue on dialysis. The goals set by CMS are, by 2026, per the Statement of Work contract, achieve a 20% increase per network service area in the number of patients added to the kidney transplant waiting list. Each year, there is a new goal, which will equal a 20% increase by 2026. The second goal is by 2026, per the Statement of Work contract, achieve a 30% increase per network service area in the number of patients receiving a kidney transplant. Each year, there is a new goal to reach, which will equal a 30% increase by 2026. In order to reach these goals set by CMS, the network organizations use quality improvement methods to increase the quality of care and the performance at the dialysis facility level. The work also extends to transplant centers and other stakeholders in the ESRD community. All right, the next section is the ESRD Quality Improvement Program, also referred to as the ESRD QIP. The ESRD QIP is an incentive program separate from the 2020 AAKH Executive Order, separate from the CMS ESRD network goals. All right, this program's intent is to promote patient health by providing financial incentives for renal dialysis facilities to deliver high-quality patient care. This program can reduce payments to renal dialysis facilities that do not meet performance standards or measures. Measures change annually and are assessed, and the assessed performance is from 2 years ago. So, how does QIP align with transplant? Actually, let's go back. So, the Centers for Medicare and Medicaid Service administer the QIP to promote high-quality services in outpatient dialysis facilities that are treating patients with end-stage renal disease. It was the first of its kind in Medicare. The program changes the way that CMS pays for the treatment of patients with ESRD by linking payments directly to performance and quality of care. So these types of programs are known as pay for performance. We reviewed the prospective payment system that is still in place, This is considered pay for performance. This program fosters improved patient outcomes by establishing incentives for facilities, financial incentives to meet or exceed performance standards. So how does it align with transplant? There is a clinical measure called the percentage of prevalent patients waitlisted, PPPW. This clinical measure is housed under the care coordination domain in the QUIP model. So what is it? This is the percentage of patients at each dialysis facility who on the kidney or kidney pancreas transplant waitlist averaged across all patients on the last day of each month. So this percentage is calculated every month and a higher rate is desired. There are two points I want to make about QUIP and how it affects transplant. So a prevalent patient includes a patient in the workup phase. So you still get credit for patients that are in the workup phase pending full activation on the list. The second point I want to make is a patient who is deemed not eligible due to a non-modifiable condition as indicated by the transplant center is not counted. So it doesn't harm your facility if the transplant center deemed them not eligible due to non-modifiable medical conditions. That's great for the percentage. This measure is calculated in your facility's total performance score. So the total performance score that a facility receives determines if there is a payment reduction. The payment reduction applies to all Medicare payments to the facility in that payment year. So the QUIP is a pretty big deal as it affects your facility's reimbursement for care provided. On this slide, it's a picture of your what your QUIP scores, your posters look like in your facility. There should be an English and a Spanish version. There is no facility indicated on these QUIP posters, as these are just sample posters, but this is what it looks like at your facility, and you can, it's there for patients and the facility members to know what the performance score was for that year. All right, so we're going to switch gears now and talk about the first of two payment models. So the end-stage renal disease treatment choices payment model is the first one. That's normally referred to as the ETC model. And the second one is the kidney care choices models. So the first one we're going to go through is the ETC payment model. So this model is intended to encourage greater use of home dialysis and transplantation for Medicare beneficiaries to increase quality of care, quality of life, and reduce costs. Those are our goals: increase quality of care, increase quality of life, and reduced overall costs. This model is included in that 2020 AAKF executive order. The model began January 2021 and will continue through June 2027. This model incentivizes home dialysis and transplantation by financially rewarding the facilities and clinicians. The payments are made based on the use of home dialysis for patients and the facility's transplant rate. This model is considered the first CMS Innovation Center model to directly address health equity. So I want to point out on the screen, there's a big sticker that says mandatory. This is important because if your facility is selected to be in this model, it's mandatory. You don't have an option. And we'll go into that on the next slide. So is my facility involved? It's a big question. CMS selected end-stage renal disease facilities and managing clinicians to participate in the model. Once again, CMS selected them. It was not a choice. According to the location, according to these facilities and the clinician location in randomly selected geographic areas. So the idea was they were going to randomly select facilities and managing clinicians, and the areas that they selected would account for approximately 30% of the ESRD facilities and managing clinicians across all 50 states and DC. The geographic region unit of selection is called the hospital referral region and is indicated by zip code. So if you don't know if your facility is a part of the ETC payment model, what you can do is you can venture to the link on the screen or utilize the QR code. It's a spreadsheet that has the hospital referral region and zip codes. If your facility falls into that zip code, your facility has been selected to be a part of the ETC payment model. The next model we're going to talk about is the Kidney Care Choices models. So there's 4 models that make up the Kidney Care Choices models. These are 4 models that have strong financial incentives for healthcare providers who manage patients with chronic kidney disease stages 4 and 5 and end-stage renal disease to delay the onset of dialysis and promote kidney transplantation. This began January of 2022 and will continue through December 2026. These models incentivize preemptive transplant, improved beneficiary transition to dialysis, and more appropriately timed dialysis initiation. The big picture on your screen says voluntary, and that's important for this model because it is voluntary. The providers who decided to be a part of this model chose to be. On this screen, we have an infographic of the ETC model versus the Kidney Care Choices model. So you do have the effective dates. It tells you when these went into effect. It talks about if it's a mandatory or voluntary model, who the beneficiary population is. Is it just dialysis patients? Is it ESRD patients? CKD patients? It tells you that in the second bullet. Which providers it targets. What is the emphasis? Does it emphasize home and transplant? Does it emphasize progression and cost-effective care? How the payments are adjusted, and then also if there's any financial bonuses involved in the model. That's what the infographic is telling you. All right, so the last section that we're going to talk about is the State Surveyor Measurement Assessment Tool. Let's give you a little bit of a background. So the Surveyor and Certification Program certifies end-stage renal disease facilities for inclusion in the Medicare program. They do this by validating that the care and services of each facility meet specific safety and quality standards, also known as the conditions for coverage. The State Surveyor Agency conducts these surveys. The Measurement Assessment Tool is a tool that houses the sections of the state survey that pertain to home and transplant. This is a picture of what the Measurement Assessment Tool looks like, the MAT, M-A-T. The Measurement Assessment Tool is a 2-page summary of the standards that are used while assessing facility compliance with regulatory requirements. The MAT is formatted in 5 columns. It includes a B tag, what the standard is, the measure, the expected values, the reference, and where the surveyor should find the information during a survey. The following are requirements for the conditions for coverage in the Measurement Assessment Tool as it pertains to home and transplantation. I'm going to go through what the Measurement Assessment Tool looks like and what it's telling you as a provider. That's important to know. So Section 494.80, title is Patient Assessment. The V tag is V513. What it states is the interdisciplinary team, patient designee, RN, social worker, or registered dietitian and physician must provide each patient with an individualized and comprehensive assessment of need. How is that going to be surveyed? It states that a chart review will be conducted to ensure documentation of the reasons why a patient is not a transplant candidate. So as confusing as the Measurement Assessment Tool is, it tells you what the expectation is, what that standard is, and how it's going to be evaluated. And so you as a provider need to know that they are looking for the individualized, comprehensive assessment of need, and it's going to be a chart review to ensure the documentation of why a patient is not a transplant candidate. The next VTAG that pertains to home and transplant is in section 494.90 under plan of care. There's actually two VTAGs that go with this in this section. It's V554 and V562. It states that the interdisciplinary team must collaboratively develop and implement a written, individualized plan of care that specifies the services necessary to address the patient's needs. It states that a chart review will be conducted to view whether a home dialysis referral or a transplant referral has been placed based on candidacy or a reason for non-referral. So there will be a chart review indicating whether the referral was placed or why it wasn't placed. Documentation in the chart must be present stating that patient education and training was conducted regarding treatment options. So those 3 VTAGs and 2 sections in the measurement assessment tool tell you the rules of the game and what's required during a state survey. All right, so I wanted quickly to go through some resources to help you at the tail end of this course. So first, I'm going to show you how CMS goals, payment models, and quality incentive plans align to promote home and transplant modalities resource. This resource is a quick guide based on the information that you learned today. This resource should be used to educate not only yourself, but other staff members on the different goals and incentives that are at play, which guide your day-to-day work and guide your goals at the ground level. Included in this resource are links and QR codes to find out more information regarding these topics. The IPRO ESRD network also has many tools to increase transplant and home transition. So ESRD.ipro.org and IPRO Learn have many resources that can aid your facility in increasing home therapy and transplant numbers. We have patient and provider education on reducing transplant wait times and living donation options. We have workup appointment checklists that can aid your patients through the process. We have peer mentoring tools, and we have tips for positive referral outcomes. There is also education on home dialysis, PD and home hemodialysis, how to allow the patient to make the best treatment choices for their lifestyle and capabilities, and so much more. Lastly, I want to thank you for taking this educational course. You must now complete the post-test in IPRO Learn and achieve at least an 80% to receive your CEU credit. If you have questions, please reach out to the help desk, and our team will get back to you with any issues that you may be having. I hope you have a good day.